All right, I think I'm going to get started and wait for, as other people sort of sign in, you can, the most important part is hearing David Lepofsky's talk. So people can sort of come in as I'm beginning the intro. So welcome to the 24th annual conference hosted by the Center for Clinical Ethics. And thank you so much for joining. My name is Michael Sego, and I'm the Senior Director of the Center for Clinical Ethics and the Ethics Lead at St. Michael's Hospital. The Center for Clinical Ethics is based at Unity Health Toronto, but we also provide ethics services to 9 other healthcare organizations. So we'd also like to warmly welcome those of you joining us from Baycrest, Copernicus Lodge, City of Toronto Long-Term Care Homes, Lakeridge Health, Scarborough Health Network, Runnymede Healthcare, Toronto Grace Healthcare, St. Joe's Hamilton Health System, and the Waypoint Center for Mental Health. So welcome. I'd like to begin by acknowledging that the land around Unity Health is traditional territory of the Haudenosaunee, and most recently, the territory of the Mississaugas of the New Credit First Nation. This territory was subject of an agreement between the Iroquois Confederacy and the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. This territory is also covered by the Upper Canada Treaties. Today, it is still home to many Indigenous people from across the island, and we are thankful to have the opportunity to work in the community on this territory. It is our collective responsibility to recognize this land as traditional territory. With gratitude, we say miigwech to thank the Haudenosaunee, Mississaugas, and other Indigenous peoples for taking care of this land from time immemorial and for sharing this land with us who are newcomers. Out of this gratitude, we are called to treat this land, its plants, animals, stories, and its peoples with honor and respect. The theme of this year's seminar series is human rights in healthcare, and we have 4 weeks of talks that look at various aspects of this theme. I would like to note one error in a previous version of the agenda. Dr. Smiley's talk will take place on Wednesday, November 23rd, not on the 15th as previously written. This was our error, and we've updated our website and registration page. Ensuring that patient, family, community members' perspectives is heard has been a tradition of our conference going back 20 years. Since the inception of the annual conference series 24 years ago. And including that patient and family voice was truly innovative at that time and a brainchild of Dr. Hazel Markwell, the former executive director of the Center for Clinical Ethics. To recognize her contribution to clinical ethics and ethics education more specifically, we named an honorary lecture in her name. It gives me great pleasure to introduce Mr. David Lepofsky, this year's recipient. Mr. Lepofsky fits in a unique category since he both has lived experience with a disability and is an expert in disability rights and advocacy. I can't think of a more qualified individual to deliver the Dr. Hazel Markwell Honorary Lecture. David is a visiting professor of disability rights and legal education at Osgoode Hall Law School and past adjunct member of the University of Toronto Faculty of Law. He holds volunteer leadership roles in the disability community. He's chair of the Accessibility for Ontarians with Disabilities Act Alliance. He's also a member and past chair of the Toronto District School Board Special Education Advisory Committee. He's also member of the Kindergarten to Grade 12 Education Standards Development Committee appointed by the Government of Ontario to recommend reforms to tear down barriers impeding students with disabilities. Over the course of his distinguished career, he's held many different senior legal positions in government and has received multiple awards for his service. Mr. Lepofsky will speak and there'll be time at the end for some questions, and Alexandra Campbell, an ethicist at the Center for Clinical Ethics, will moderate the session at the end. She will also provide instructions on how to receive CPD credit if you are a physician, as well as a link to evaluate the session. So without any further ado, David, I'd like to hand it over to you. And again, thank you so much for joining us today.
Thanks so much for including me and honoring me with this opportunity. And thanks to all of you for coming to listen. We live in a world that is designed and operated largely on the most absurd premise. How's that for a starter? It is designed and operated largely as if it is going to be used and enjoyed by people who have no disability, no physical disability, no sensory disability. I'm a blind person. No intellectual or learning disability, no neurological disability, no mental health issues, and so on. No disability at all. The buildings where we go, the public transit we ride, the stores where we shop, the goods that we buy there, the goods and the services, including healthcare services, even the laws that we operate under are all designed and operated from the outset on that premise. Now, no one sat down to conspire against us, people with disabilities. Nobody wants this. But guess what? The world wouldn't look a whole lot different had there been such a conspiracy. As a practical matter, whether good intentions or not, that's where we are. Now, there's more awareness that this isn't good. There are more efforts to change it, but that overwhelming reality still faces us. Who suffers from this? Well, there are those of us who now have a disability. In Ontario, 2.6 million. Across Canada, over 6 million. Around the world, upwards of 1 billion. Those numbers are huge. But although huge, they understate the victims of this pattern of how our society works. Why? Because everybody either has a disability now or gets one later in life. We are the minority of everyone. So a world that is designed and operated on the assumption that we're not there or aren't going to fully participate is a world that ultimately hurts us all. Let's talk about the healthcare system. It is no exception. In fact, it is typical of what I'm talking about. Absurd as it sounds, the healthcare system and the services delivered in it are designed and operated day to day so often as if the people using it have no disabilities, even though disproportionately the healthcare system's users, the customers, are people with disabilities, either permanent, episodic, or temporary. As we know, the most use we make of the healthcare system is in the last years of our life, and the greatest cause of disability is aging. Now, not only does this not make sense, but it's something that is easy to change. I know it sounds like a big daunting task, but it's actually easier to change than in a number of sectors of society. Why is that? A few reasons. One, it's a publicly funded system. So there's the capacity at the center for there to be coordinated planning and centralized strategy backed by funding. Not only that, reform helps everyone, and there are a lot of people who are hurt by the status quo. And the third reason is that that the healthcare system is in a state of incredible flux, of transition. And when you're in flux, when you're in transition, when innovation is at the center of how a sector of the economy is operating, there is ample opportunity for reform. So what kind of barriers are we talking about? And what can we do about it? Well, let me jump ahead to what we can do about it first, because as you're listening to this, you might think, okay, I'm going to listen, but what the heck can I do? I'm just an individual player. Lots of you can do lots of things, but you can't do it alone. And therefore, the coalition I lead, the Accessibility for Ontarians with Disabilities Act AlliNCE, a nonpartisan volunteer coalition, has been advocating since 2009 to get the Ontario government to pass a regulation called a healthcare accessibility standard that would set out detailed requirements in this area. Now, all the barriers I'm going to describe, I should tell you at the outset, they're all illegal right now. They're all illegal. They violate the Human Rights Code. They violate the equality guarantees to people with disabilities and the Charter of Rights, but they require people with disabilities to litigate barriers one at a time, one after the other. A healthcare accessibility standard, that would change things by setting out comprehensive standards that the government would enforce that make it clear what needs to be done and when it needs to be done by. The government agreed, provincial government agreed to create one back in 2015, and we are still slogging to get them to implement it. A bipartisan advisory committee with healthcare system representatives and disability representatives having equal seats at the table made a comprehensive series of recommendations. We're waiting for the government to act. They're going to share with you in the chat contact information on us, but you'll find that on our website, there's a whole page devoted to this, AODAalliance.org/healthcare. Well, with all of that, let me dive into what we need. and what the barriers are. The goal is a barrier-free healthcare system, one in which patients with disabilities and caregivers with disabilities can fully participate. That is a system where we do a couple of things. We find out and tear down the barriers that are there now. We make sure we never create any new ones. And we have in place an effective system where a patient can ask a healthcare provider to accommodate them in the meantime. So what kind of things would a barrier-free system, healthcare system include? And what are the barriers we face now? Well, the first thing, sequentially, is we need, as patients with disabilities, accessible information on what healthcare services there are and where to get them. That means the information has to be provided in a format that we can read. Now, people like me who are blind have lots of access technology to read, but if the information is posted on a website that is not designed to be accessible for our access technology using well-known international standards for web design, or if the information is handed out in print with no alternative format options, then we've created barriers for people with vision loss, people with literacy issues, people who are dyslexic, and people who can't navigate that kind of printed information for any other disability reason. You have no idea, and I don't want to personalize this too much, how many times I've walked into a doctor's office and been handed a form to fill out on a flat thing, a piece of paper. There is ample technology on how to make that available and how to do it cheaply, easily, and quickly. But that kind of information, if you can't get access to it, if you can't even find out what services there are or where to get them, or you can't sign up for them, you got a problem. Example, when the provincial government set up portals for us to, or allowed drugstores and others to set up portals for us to sign up for for the COVID vaccine or now for the flu shot, if those websites are not accessible, they're not designed to be accessible, we have a problem. Now, all of those inaccessible websites, as I said, violate the Human Rights Code, so they're all illegal, but we at present are left to litigating them one at a time. Now, let's say that we can find out about the healthcare system in terms of accessible information. Then we need to be able to get to the healthcare services at an accessible location. That doesn't just refer to the venue where the healthcare services are, or pardon me, the building in which they're located, more about that in a moment, but the location has to be on an accessible transit route or have accessible parking nearby. If the only accessible parking for those who can drive and have a car is blocks away or costs a fortune, we've got a barrier. If the hospital or healthcare center is not an accessible route of travel, there is no accessible public transit to get there. The public transit system may go there, but it doesn't have accessible vehicles or stops, then we have a barrier. If a healthcare system operates on a system of fixed time appointments with no flexibility, your appointment's at 2, and if you miss it at 2 for any reason, you're out of luck. Well, that is a barrier for people who use paratransit, where schedules for arriving are not guaranteed. You can book a ride, you can book it to get there early, but the paratransit vehicle could end up being late. And we have reports of people with disabilities who, despite their best efforts, show up late, may miss their appointment, may be charged a fee for missing their appointment due to healthcare transportation barriers. Let's say we get to the location. Let's say we've gotten the information, it's accessible, and we've found an accessible way to get to the location to get healthcare services. Then there's the problem of the building itself. Unfortunately, well, you might think that, of course, we would have hospitals and healthcare facilities would be in accessible locations. How on earth could we have a facility that isn't? The opposite is the case too often. Not only old hospitals and old healthcare facilities, but new ones. I went into the then brand new Women's College Hospital just a couple of weeks after it opened a few years ago. And with a reporter, did a bit of an expose on how many barriers were designed right into the building. Let me give you two examples. They had accessible parking in the building. That's great. But to pay for parking, you had to use an electronic kiosk. The electronic kiosk was built into the wall at standing height. So the wheelchair accessible parking spot, you park there, but when you go in the door of the brand new hospital and you want to pay for the brand new parking, you got to stand up. Somebody designed this. Go down to the ground floor of the Women's College Hospital at the time. I haven't checked to see if they've changed it. Good news, they had Braille in front of the bathroom, so you can know which bathroom it is if you're visually impaired. I read the Braille. It didn't say men or women or family. It said 1224 or something like that. It was a room number. I don't know about you. I've never checked the room number of a bathroom. Again, somebody planned this. We need, now you might think, well, don't we have standards to ensure accessible buildings? Doesn't the building code cover this? Sadly, the building code's accessibility requirements are inadequate. Training for architects is inadequate. And standards under our Accessibility for Ontarians with Disabilities Act are scant and don't cover most of these barriers. So what do you do about that? Well, there are steps that can be taken now. We need to proactively facilitate or put in place easy to deliver services to help people get around a healthcare facility. That might mean including having a volunteer at the front door who's available to guide someone with a vision loss or assist somebody with a mobility disability to find an accessible route through the maze to the venue where the services are. Or it might mean a doctor's office or other healthcare provider letting their customers know automatically when you make an appointment and an email confirms, if you need assistance getting from the front door to our office, please let us know. Here's the number to call. We'll facilitate it. It may only take a couple of minutes, but it can make all the difference. Remember, look at how far into my talk, and we haven't even started on what goes on when you actually get to the healthcare service. A next barrier that people with disabilities can face is effective communication with their healthcare provider. Now, as you can understand, effective communication is absolutely indispensable to effective healthcare services. You know that, I know that, and the Supreme Court of Canada held that in 1997. They held it was unconstitutional for British Columbia to fail to provide sign language interpretation in the emergency ward where needed. It took years for governments to respond, and there's still ineffective responses. We hear reports of it over the years. I can't tell you anything right now, but in recent years, we get calls from the media where it's not provided. The good news for you is there are easy ways to provide those effective communication supports in a way that couldn't be done 25 years ago. Back then, if you wanted to get a sign language interpreter, you had to actually find one and bring them into your location. Now it can all be done over the internet by remote services, either sign language interpretation, captioning, and there are even apps that can be used to automate some captioning. Not 100% accurate, but a heck of a lot better than not having any effective communication alone. Now, that's again, effective communication is just one of the kind of barriers. The next kind of barrier we can face is in diagnostic equipment. Too often, diagnostic equipment has been designed on the assumption that it's only for people without disabilities. Now, just a small iteration of the same problem I've described before. What do you do about it? Are there standards for accessible diagnostic equipment? Well, yes, there are, but sadly not here. We've been trying to get the government, which funds a lot of this diagnostic equipment, to set provincial standards and ensure that only accessible diagnostic equipment is purchased with public money. But we've only been trying that since 2009, so 13 years. The US Access Board, a regulatory advisory board in the United States, years ago came up with proposed standards for accessible diagnostic equipment. I strongly encourage any healthcare provider to look to those standards to try to ensure that when you buy diagnostic equipment, it can be used by everyone. The next kind of barrier we can face, let's say you can get in, let's say the diagnostic equipment can be used, let's say you can even effectively communicate. The next problem we have, and it's one that's unfair both to patients and to physicians, in the case of healthcare, private practicing doctors, are the funding constraints on how much time to spend with a patient and how many conditions can be discussed at one time. Some people with disabilities need more time. They may need more time to undress and dress. They may need assistance. They may have a speech limitation, which takes it longer to communicate. There are any number of reasons why that can take longer. But if doctors are and other healthcare providers are artificially constrained to time constraints of how much you can bill for, doctors either have to eat the time or not serve the patient. Similarly, for a patient with a disability, if the trip to the office is an arduous one, if they have a chronic fatiguing condition or chronic pain, they will want to bundle up as many conditions as they can to a visit, and any artificial limits on how much can be discussed at one time can serve a huge barrier for them. Other examples of barriers can include protection of individual privacy. Now, here's one that's easy to fix. I gave the example before, and I'm going to draw on it again. The doctor's office where I walk in, or any other healthcare provider, where you're waiting in the reception area and the receptionist hands you a document to fill out with your medical history. Now, first, it's not accessible. But second, even if an office is prepared to provide you with assistance filling it out, and many do, the problem is that you need to be able to fill it out with that assistance in private. I've actually seen and heard from others about situations where a receptionist kindly offers to fill it out and starts asking all those medical questions, which can be quite intrusive, in the lobby seating area of the medical office. Now, I suspect you, like me, don't really want to be asked personal questions in that kind of setting. We need an avenue to get information to communicate about our needs, about our medical history in private. Now, here again, it shouldn't be too hard mostly to do that. It may be a matter of just going into a treatment room and having a private, brief conversation. That needs to be a practice. That needs to be a policy. That needs to be reinforced. It shouldn't be left to the patient to say, excuse me, can we talk about that somewhere where I'm not sitting in a room full of strangers? Let me then give you the example of personal supports. There are some people with disabilities who need some kind of personal support or assistance in the context of receiving a healthcare service. I gave you an example earlier that's typical for me, walking into a large hospital and wondering if someone can just guide me through the maze from the front door to the particular location where I am to report. But that's just one example. There are some people with disabilities who need certain supports either while in hospital or while interacting with a healthcare provider. It may be attendant care. It may be certain kinds of personal care. It could be a communication intervener, and so on. This became a problem early in COVID when hospital lockdowns and strict limits on who could come in cut some of these providers off from the facility. But let me give you an example that I think will resonate for everyone. when we have a patient admitted to a hospital, I don't want to preoccupy with hospitals, but it's a good illustration. And they are admitted for some kind of acute care issue. The hospital gives you food, and they put that tray in front of you. And when it's time for you to, when you're done, they come and get it. So picture the patient who has Alzheimer's or some form of dementia, and a meal is brought and it's left there. And this is a person who needs assistance to eat and needs to be told the meal is there, it's time to eat it. Well, if a hospital doesn't provide that support, even if the family asks, then what ends up happening is an orderly comes along a few minutes later and simply sees an untouched meal, says, oh, I guess he wasn't hungry, and takes it away. Barrier to access something as fundamentally basic as being able to eat. It's a really serious issue, but we don't necessarily have in place the systems to make sure that these issues don't happen. I talked earlier about the issue of information in an accessible format regarding the availability of services and where to get them. That issue rears its head again when it comes to receipt of other healthcare information in conjunction with treatment. A healthcare provider who says, oh, we have a pamphlet here on this condition, please read it over, or forms material they want you to read before you sign a consent, or the label on a prescription bottle to tell you what you can take or what it is, when to take it, and what the risks are. All of those things assume the ability to read print. And for people with print disabilities, the failure to provide accessible alternatives, no matter how cheap and easy, can become a serious barrier. Alex, if it's possible to run that video clip I gave you, or the audio clip, this was covered on CBC The National just this past Sunday night, the issue of accessible prescription labels. Can you run that now? Is it available?
Yeah, I think
I can run that right now.
1 second, David. We will do that.
If it's a problem, I could carry on and then we can run it a little later. You know what, I'm not actually hearing anything, so I'm just wondering if I might just carry on. You can.
Michael.
Oh, sorry about that. I thought everyone could hear. Okay.
No, yeah.
I'll just let you carry on then.
Okay, I think when you do your screen share, you've got to click to share audio. But just to summarize, there has for years in the US been available a technology that drugstores can opt into, where you get a talking prescription label. And now you can scan it with your smartphone. It doesn't cost anything to the customer. And you can know what's on your prescription label. But CBC's national news program covered the fact that there are some drug chains here and drugstores that won't carry it. And while it's not in the story, I understand as well, there are some who will make it available, but not an on request right then. You got to wait a couple of days. Well, sometimes you got to fill your prescription right away. You can't wait a couple of days. So let me shift from all of this to talk about a step or a barrier we have that could cut across a lot of this. And this applies to both the larger institutions like a hospital and the smaller healthcare providers like an individual office where there are physicians or physiotherapists or other allied health care providers. And that is that in a system full of barriers, even though there are those of us who are pushing to get comprehensive standards passed to remove the existing ones and prevent new ones, we're going to have to live with barriers for quite some time. So what we need to help get around that is a fast and effective system to ensure that individuals with a disability can get accommodated, can get assistance in working around these. The healthcare system and healthcare providers have a strong legal duty to accommodate the disability-related needs of people with disabilities. And on the list of resources that I'm sharing in connection with this video is a video lecture I've given, which is an introduction to the duty to accommodate for those of you who may have heard about it, but don't know anything about it or how it works. That's available on YouTube if you just search on David Lepofsky, Lepofsky, and duty to accommodate. You'll find it. But what do you do? Well, the duty on healthcare providers includes, in my view, a duty to provide proactively a welcoming environment for people with disabilities to ask for and get disability accommodation. It's not enough to just wait for it, wait for a request. Some of your patients won't know they can ask. And so what that could include is some signs up in the office that for people who can read print saying, if you have any disability related accommodation needs, we want to do our best to help. It can include if you have everybody's healthcare office has some kind of interactive voice response system. The audio announcement could simply say, as part of it, by the way, if any patients with disabilities need an accommodation to assist you in getting our services, we want to do our best to help. Here's who to call. Part of this involves designating someone who is the point person to get the requests. Because people, if it's a large facility like a hospital, or even if it's a smaller one, people with disabilities don't necessarily know who to ask. And it also means at the service provider end, making sure you've taken some steps to train them up. They can't know every possible accommodation to be delivered, but they could at least have access to some information on what to do or who they should go to internally if they need some assistance. Just having someone to talk to in a large healthcare provider or other organization to make the request and see what you could do, that can make a huge difference. It also, if anybody watching this is at a managerial level, helps you track what kind of recurring requests you get so that you can organize to better meet them in the future. Other things that a healthcare provider can do to assist this is to put someone in charge. A large organization should have a chief accessibility officer to make sure your services, your facilities, your plans are accessible. Your board should have an accessibility committee, your governing board. Same goes for self-governing professional bodies. Let me take my last few minutes to just talk about what I would call some of the newer barriers that we are facing in our healthcare system as patients with disabilities in Canada. And these are incredibly troubling. Even though everything I've told you about up to now is eminently fixable, sadly too common, and really significantly contrary to our human rights legislation, not just a question of medical or healthcare ethics, a question of fundamental law. But going a step further, these are two recent developments that are making things worse for us as people with disabilities. And both broach upon healthcare and bioethics considerations. The first has been the response in the healthcare system to the COVID pandemic. Any number of new barriers were created against people with disabilities getting service during the pandemic. Now, the pandemic was a nightmare for everybody. It required a lot of scrambling and innovation. You certainly can't expect perfection, but making things worse becomes a serious problem. I gave an example before of the blanket rules initially on the lockdowns that said like nobody in to the healthcare facility except certain like one family member, maybe none, which had the effect of precluding patients with disabilities and too often from getting access to personal supports that the healthcare provider didn't give, that the patient relied on family members or others to provide, was a serious problem. But it got worse starting early in the pandemic, once it was realized that there could be the crisis of a shortage of critical care. Knowing that this was going on elsewhere in the world, the government understandably decided to the Ontario government plan in advance for what on earth we will do if there has to be some kind of rationing or triage of critical care among patients who need it to save their lives. The problem is that the handling of this from top to bottom was, from a disability perspective, terrifying and disastrous. What ended up happening, to summarize, is a bioethics table was appointed by the government who created a secret protocol shared with hospitals, leaked to our community, made public with disability advocates pointing out that it was riddled with disability discrimination. We were then afforded the opportunity, after the media shone the light on it, to talk to the bioethics table. We raised any number of serious concerns. I was part of that. In fact, you can see one of my presentations on YouTube. And I was just one of many. But what resulted was a successor critical care triage protocol sent to hospitals on the 13th of January, 2021, which itself was again replete with disability discrimination. If there was going to be triage, there were going to be decisions over who lived and who died that were directly, in some cases, a function of the severity of your disability. We said it was wrong. We said it was illegal. And the fact that it was secret led us, when it was leaked to us, to post it on our website and ultimately to secure national media attention. Well, what was done about it? Well, the good news is, thankfully, we, at least as far as we were told, no one actually had to resort to formal critical care triage. We managed to dodge that. But the damage still remains, because hospitals were invited, encouraged to, and we understand did engage in training sessions on how to undertake critical care triage using that protocol, under the misguided assumption that if they do it, somehow they're protected. We actually had said very publicly that any doctor who made a decision about allocating critical care on the basis of it was doing so at their peril, because of the rampant disability discrimination that was embedded in it. But the problem we have now is that now hospitals in Ontario have had embedded in them the mentality that's built into it, as if it's okay, without being warned that it is embedding unwarranted, unlawful disability discrimination. When training was done by doctors, on a video you can see on YouTube on this, they were told that the community and human rights groups were consulted. What they weren't told is that we in the Human Rights Commission itself fundamentally objected to key parts of it. And that was a serious problem. So the first worry about this has been that a mentality about how medical rationing is done can include the kind of thinking that was embedded in that protocol, that's okay, that there was training on it, has a fearful impact on people with disabilities. There are people with disabilities during the pandemic who were actually said they were afraid to go to hospital for needed medical care because they were afraid that there would be this kind of triage, even if no such triage was announced. That alone is a cause of concern. The embedding of this mentality is a deep concern, but there's one other harmful effect. Even if the government and hospitals never invoked critical care triage formally, never said, we've got to do this rationing. We warned of a deep worry of what we call trickle-down triage. The fact that this mentality could lead nursing home administrators to decide, oh, this patient may be critically ill, but there's no point sending them to the hospital. They'll get triaged out. Or ambulance attendants and emergency medical technicians deciding what treatment to start applying on the way to the hospital, or in fact, whether to go to the hospital out of a perception of what might happen there, or decisions within the hospital itself. Now, again, none of this can be monitored by us because it was all done in secret. This has been a matter of very serious concern. Let me turn for my last 4 minutes to an equally serious concern, and that is the controversial subject that is called medical assistance in dying. We don't like that euphemism. We think it's trying to make it sound a little too gentle. It's doctor-assisted suicide. It's a patient who wants to commit suicide and is asking a doctor to help. Now, it's a controversial subject. There's room for a broad spectrum of views on it. The key point I want to make for you, to just make you aware of this as a new barrier facing us, is this. The concept of it and the making of it available a few years ago in Canada, I think, was understood by the public as one thing, but it's kind of running amok and gone far beyond that. We are far beyond a legal regime where someone who is at the end, near the end of their life, and they are in excruciating physical pain, and they are seeking doctor-assisted suicide as an alternative to that pain because there is no medical treatment for that pain. We are now seeing situations where someone media reports of people seeking doctor-assisted suicide because they have serious environmental sensitivities. They live in assisted housing and they can't find an apartment unit where they're not next door to a smoker, because it's causing the suffering is not an untreatable medical condition. It's a social construct that's forcing them into that place. There are people on that are raising concerns that they are on public assistance, social assistance like ODSP, because of their disability, who are consigned to languish below poverty lines and are finding life insufferable because of that, and are seeking medical assistance in dying. There are people who, under the legislation, it would be open to a person to say, I've gone blind, I can't live like that. I just want a doctor to assist me by killing me. And with the addition now of it being extended to people with mental health conditions, we are facing the absolutely perverse world where a patient's in a psychologist's office, and they start talking about wanting to commit suicide. In the old days, the psychologist would take them to the emergency room and try to get them psychiatric assistance, waiting hours, being told there's a long delay. Under the new legislation, what's the hospital to do? Say, well, we got two options. You can wait in line for days, weeks, months for psychiatric care, or we've got another option, which is a whole lot quicker. We've got a helpline from the federal government, commendably, for people who are concerned about suicide, committing suicide. But we're also talking about doing the exact opposite. Let's make it easier. Let's actually facilitate it. Let's government fund it. There's a serious problem here. And underlying all of this, there is no effective monitoring to find out whether different doctors who are administering what is admittedly vague legislation are applying in their own minds different standards. We have more safeguards for an individual who wants to surrender their liberty, or who agrees to surrender their liberty to the state for a 5-day prison sentence, than someone who wants to voluntarily surrender their life. There is something really weird going on here. And I will tell you that this is not only a serious issue, but it's found its way to the House of Commons because the same standing committee that is considering the legislation that's liberalizing medical doctor-assisted suicide well beyond what I believe the public thinks it's and understand it's all about, is also right now considering a bill to create a Canada disability benefit. Financial assistance to help finance those people with disabilities living in poverty. What does that have to do with this conversation? Because it's been raised with the committee that that too many people languishing in poverty who have disabilities are considering the alternative of doctor-assisted suicide. We got to fix the poverty rather than make it easier for them to commit suicide in a situation where, frankly, they shouldn't have to even think in those terms. Well, let me wrap up. That's a kind of a depressing note. Let me wrap up with an incredibly positive note. Every single one of you watching this can make a difference. Initially, when you hear about these kind of barriers in the system, it is absolutely natural to think, oh my God, there's so many barriers. There is so much to do. This is going to take so much work. I'm just one person. I want to deliver healthcare. I want to provide supports, or I'm a bioethicist giving advice. What can I do? And in any event, whatever I did do was going to be just a drop in the bucket. I want to turn that around. Let me tell you that absolutely anything that you do to help address any of these barriers can make a difference. If every single healthcare provider, whether it's a primary health care provider, an allied healthcare provider, whichever you are, if you build into your practice, letting a patient know from day one, by the way, if you have any disability-related accommodation needs, let me know. I want to help. I want to do my best. That alone will be transformative. It takes no time, pardon me, it costs no money. And I think you'll be happier when you do it. If you look at the facility where you're working, whether it's a big one or a small one, and you look for, and you say, do we announce to people that if they need assistance because of a disability, here's who to call? And if the answer is no, put your elbows forward, start pushing for it. That alone can make a difference. If you add to any meeting, any discussion where you're planning some future initiative, some future wing, some change of any sort, if you're the one at the table who says, by the way, what are we doing to make sure that this is going to be accessible to patients with disabilities? Just asking the question helps you become a healthcare barrier buster for us. It can make a difference. It will make a difference. You will be proud of what you will accomplish, because if all of you do it, it's going to start a momentum towards change. I want to thank you all for the opportunity to talk to you, and I really look forward to taking any questions.
David, thank you so much for such a thought-provoking presentation. I always walk away from listening to you speak with so much food for thought, and today has certainly been no exception. I have been receiving some questions in the chat, and if you're okay with it, I'm just going to start reading some of them.
Why don't you give me a few and I can try to bundle answers.
Okay, well, they actually come in bundles. So I'll start with a question from Bob Park, who is a bioethicist, who says, always good to hear from you. Thank you. How can we ensure that healthcare staff don't deny access to trained workers who can facilitate communication? Staff have been trained that they have to abide by the Healthcare Consent Act hierarchy of decision makers, and they use it to deny access to trained workers. Do our laws need to change to ensure that communication, to ensure accommodation for nonverbal patients? Also, do we need to nuance our education of healthcare professionals to ensure that they don't uncritically apply the Healthcare Consent Act? He writes, I believe the Healthcare Consent Act is both unsafe for those with disabilities and culturally unsafe. I have had consults and am familiar with cases of denial of access of trained workers. Thank
Okay,
you.
let me start by saying that the Human Rights Code provides that no one shall do anything which directly or indirectly causes the violation of a right. So someone who does anything which directly or indirectly impedes effective accommodation of a patient with a disability when it comes to services they need to fully enjoy the service and facility, the healthcare, is automatically stepping into a minefield when it comes to, and is looking for trouble. So the starting point is you got a legal issue here. You got a legal problem here. Now, whether you talk to your healthcare facilities, legal people, or whatever. So you got to understand all of these laws. It's not like the healthcare, like one law trumps the Human Rights Code. In fact, the Human Rights Code trumps the other laws. And that's something the Human Rights Code itself says. So that's my starting point. As for education of professionals, I'm going to be a little less gentle than our questioner. We need significant reform in education of healthcare providers to ensure that they understand more than what I just could cram into this 45 minutes. And we've been advocating for this for years. And in fact, the Healthcare Standards Development Committee recommended significant reforms in education of healthcare providers. I've had occasion to go and give talks, let me think, at a faculty of occupational therapy, and they really well received. I'm not looking for this for me, believe me, I'm overloaded, but there's lots of good people who do this, but it should be built into the curriculum. And just so you know, lest you sit there going, he's whining about the healthcare providers. What about you lawyer types? I'm equally actually very involved in advocating for reforming our legal education system to train lawyers to know how to serve clients with disabilities. So it's not limited to healthcare professionals, believe me. Back to you.
Thank you so much, David, for that answer. Very helpful answer. I'm going to paraphrase a question by one person who submitted a question. And what he's really getting at is about what do we do when rights conflict? So possibly an accommodation of one patient or one staff member runs into tension with what might be perceived as the right of another patient or provider. I know that's a really big question.
I can handle it.
Okay, I know you can.
No, here goes. Number one, let me give you the classic. What if somebody wants to bring their guide dog or service animal, and the healthcare provider has either a religious aversion to, or a religious discomfort with, or whatever with respect to the animal, or even has allergies. So the starting point is there is a duty to provide barrier-free services and a duty to accommodate their needs. So as a healthcare provider, and by the way, the Human Rights Commission has a really good policy on conflicting rights. I've dealt with this whole issue in a number of contexts. Typically, the first goal is see if there's a way to meet the needs of the patient and their disability in a manner which doesn't conflict with another person's rights. There are typically ways to find out if a physician, and I'm not just picking on doctors here, I'm not picking ever on doctors, but I'm not just singling out doctors, has either an aversion to or an allergy to. The question is, can the care be delivered in a way where they don't have to get that close to the individual, or there's an affirmative duty on the, I would say, on the healthcare provider to find a promptly available alternative healthcare provider. If there's another physician in the office, say, hey, can you just see this patient rather than me? I've got this issue. This is similar to in the school situation. This was raised with us if a child, a student with autism wants to bring their autism service dog to school, what if the teacher has some aversion to animals? And the answer is, all right, let's figure out how close they need to get to the student, or Can we rearrange which class the student's in so they're with a teacher for whom it's not a problem? These are solvable problems. And that really is the solution. And what we have found about the duty to accommodate generally is where there's a positive mindset of, hey, let's get it fixed. Let's find a way to do it. You usually figure out a way to do it. And if there is a state of mind of, oh, this can't work and this is a problem, there's usually a way to find out a way to not make it work. And the final point that I want to suggest, Alex, is when dealing with any of these issues, and this is kind of picking on the theme I ended my talk with, if you're not sure what to do, ask, and trial and error, try things out. If something doesn't work, okay, we tried it, and then we'll try something different. Back to you.
Thank you. I think we have time perhaps for one more question. So I was wondering if you could address this question. You mentioned in your talk about how the existence of the healthcare standard would prevent people with disabilities having to individually, like themselves, to litigate individual issue after individual issue. A very, well-known case in this area of jurisprudence is the Eldridge decision. Do you think that a health standard could have helped in such a situation to prevent the need for litigation?
Eldridge is the case that requires hospital emergency rooms to have sign language interpretation, but it goes way further by basically saying that when you deliver a program like healthcare, you got to make sure it's designed in a way to accommodate the needs of people with disabilities. We can't just have a healthcare system that's designed for people without disabilities and then tell people with disabilities, you figure out how to fit in, or we'll struggle with you as an afterthought. What a healthcare standard would do is avoid the need for every healthcare provider to reinvent the wheel. We have about the most inefficient way of solving this problem right now. We've got a provincial government that basically leaves it to every healthcare provider to decide what diagnostic equipment to get and what the accessible needs options are and whatever. And then you do as much or as little as you want. And then if somebody litigates against you, go fight them. If we were to, there are lots of, we've provided the government with comprehensive ideas. We could be bulk buying ideas to make this far more efficient. So it's not just a matter of having a standard that says, here's the kind of accessible diagnostic equipment features to have. But if we also had the government bulk buying it, so that if a doctor wants to buy the equipment for their office, it's been bulk purchased at a lower rate. That makes it easier. If a healthcare provider needs sign language interpretation, instead of them having to go to all the trouble of knowing where to look for them, if there's already someone at the center of the healthcare system who's already facilitated a service of remote sign language, so you just contact them, they've found the providers and all that stuff, that could work a lot more smoothly for you. I think there are lots of solutions that could make this system way more efficient. Of course, I know as I'm talking to healthcare providers, all chime in and go, yeah, we could give you a million other examples that have nothing to do with disability. But these are just ways that you make this low cost and easier to do, and therefore more effective, rather than leaving it to every healthcare provider to reinvent the wheel and every patient with a disability to have to fight, litigate, or just suffer from every barrier they face. Just before we go, I just want to tell people the information that will be provided in the chat, and for those of you who can't see the chat because it's not, you're watching on YouTube, if you could sign up to get more information on this from our updates. You go to our website, there's a sign up link. It's AODAalliance.org, AODAalliance.org. There's a sign up link. There's a healthcare page with tons of information. There's a page on critical care triage with a lot on that. There's a page on COVID with a lot of our efforts on that. So you can learn tons more there. And finally, you can follow us on Twitter at AODA Alliance, at AODA Alliance. Please do.
David, thank you so very much. As always, just wonderful to hear you speak. I really appreciate you being with us today. I've shared my slide screen rather, so hopefully everybody can see that physician attendees today can receive CPD credit for being here, and there's a QR code and a link. there on the screen for your use, and everyone is warmly invited to evaluate as well today's presentation, and there is a QR code for that as well, and a link, and I'm going to put that in the chat as well for people to use.
Oh, perfect. I was just going to say to minimize it. I see that it's 1:01. David, thank you so much for sharing your wisdom with us for the last hour. It really was a pleasure. And again, encourage everybody to fill out those evaluation forms and join us again next week for our sort of second installment in the speaker series. Hope everybody has a great afternoon.